Thanks to Dr. Suruchi for the kind introduction. As she rightly pointed out, the thyroid nodules have become a challenge, not only purely by their biology, as well as our ability to identify the ones that will need surgery and the ones that will not. I hope my audio and video are okay and good to go.
You're
Hello?
good, sir. You're good,
Yeah.
sir.
Okay. All right. Thank you. So let me just put it up in PowerPoint. Yeah. Okay. That's good. So we are talking of an extremely common problem that can come to any one of us, our family members, as well as our colleagues, as well as our patients. And it may not be the one that we're looking for. I mean, patients coming to us for presenting with thyroid nodules with the swelling in their neck and being examined and evaluated is one part of the story. We also have another part of the story where we have thyroid nodules being picked up by various imaging modalities, including ultrasound neck done for Doppler, CT chest done for pulmonary disease, PET scan done for another cancer. You incidentally find thyroid nodules as well. So we have two different groups of presentation, one patient driven, the other one is obviously radiology driven incidental thyroid nodules. And so the numbers of these thyroid nodules henceforth becomes quite large. And it's important not to view the nodule from a surgical lens all the time, because thyroid surgery, if not done properly, could also have significant long-term complications and comorbidities. So the question that the patients always come to us is my nodule cancerous? And that's the question that the patients will always come to us with, and that's what we also want to find out. So that question is getting answered through a series of steps. So we have a clinical suspicion. So you examine the patient, you ask detailed history, you feel the nodule, you do an ultrasound of the nodule, and then you do a fine needle aspiration. You find out if there are what is the risk of that particular nodule being cancerous through the Bethesda system. And then you decide about the patient what best needs to be done. So the nodule can be observed versus can it be operated. Sometimes you don't get a clear-cut idea from the ultrasound and cytology, so your management might in fact be a diagnostic surgery as well. The point to remember is, while we are curious to find out the risk of cancer, we should also not harm the patient in the due process. So the reason being that subjecting everybody under a surgical knife might not be this simple answer to satisfy the curiosity of is it really cancer or not, because a lot of thyroid cancers are slow growing, indolent, and do not in fact affect the lifespan or do not in fact cause significant problems in many patients. And so it's important for us to judge which patient will actually require surgery. So it's rather than becoming a simple diagnostic surgical procedure, we'll have to look into a nuanced approach into whom should we observe, whom can wait, who can undergo a hemithyroidectomy, who needs a total thyroidectomy. So that kind of a nuanced approach is extremely important, and not subjecting every nodule that comes to you for surgery. Now, this is how the American College of Radiology have given our TIRAD scoring. Well, and there are scoring systems for each of the features that you have, and you add up all these points. There are 5 categories that you have to choose, and then you get scoring system based on these points, and that will grade you from being a benign nodule to a mildly suspicious to a moderately suspicious, and finally to a highly suspicious nodule. So a TIRADS 5 will be a very highly suspicious of cancer. A TIRADS 1 or a TIRADS 2 is likely to be benign. So why is this classification important? Because if you have TIRADS 1 or TIRADS 2, your threshold for doing an FNAC itself goes up a little higher. You can wait for the nodule to be a little bigger before you plan to do an FNAC. I will not mention a size criteria because it's very personal and very inter-individual and patient-doctor based, but your chances of finding cancer in a TR1, TR2 nodule is extremely low. On the other hand, TR5 nodules are likely to be cancerous. That does not mean that they all the time will need an FNAC. Sometimes if they are very small and less than 1 centimeter, the recommendation is actually to wait. Um, uh, so you have to use your clinical judgment in deciding which ones will proceed with surgery and which one you can observe and wait. Now, the point where we get stuck is this category when we have TIRADS 3 and TIRADS 4, because they can be either way. They can be benign or they can be cancerous, and you really cannot tell. The ultrasound will not be able to tell you if it's a mildly suspicious or moderately suspicious nodule. What do you do with it? Now, the good thing about the ACR TIRADS is that it's got a fairly good sensitivity. So the negative predictive value of ACR TIRADS is very, very good. So if you have a TIRADS 1 or 2, you're fairly certain 90% of the times that you're not dealing with a cancerous nodule. However, the specificity is 70%. So if you have a TIRADS 4, TIRADS 5, sure, it is likely to be cancer, but the percentage is around close to 70%. So that's what the classification basically helps you in assessing the risk of cancer. This is from the radiology point of view. Now, next step, when you saw something on the ultrasound, you obviously will plan to do an FNAC. Now, recommendations are not to do an FNAC below 1 centimeter nodule, purely because unless you find suspicious lymph nodes in the neck and unless you find something suspicious outside the neck, definitely then the nodule will require an FNAC. Or if it's children, if it's a familial hereditary cancer, then yes, the rule does not hold true there. But in general, adult population less than 1 centimeters, you don't generally do an FNAC, because assessing features of thyroid cancer in a 1 centimeter nodule is rather unusual and difficult to ascertain. Secondly, the cancer that comes in a 1 centimeter tiny nodule is usually a PTC, papillary thyroid cancer. And if there are no lymph nodes in the neck, you can fairly confidently follow these patients. If they grow, then you can repeat the FNAC. You can do the FNAC when it's more than 1 centimeter. And that's why we don't FNAC less than 1 centimeter. But if it's more than 1 centimeter, yes, you should. If it's a TIRADS 1 or a TIRADS 2, my cutoffs are usually 1.5, 2 centimeters or more. Recommendations are, not to FNAC any benign cyst, but I need that FNAC to actually ensure that they can undergo interventional radiological procedures. So we end up doing FNAC on benign cysts. TIRADS 2, we generally wait for about 1.5, 2 centimeters. The recommendations are about 2.5 to 3 centimeters. TIRADS 3 and TIRADS 4, you could decide more than 1 centimeter to do an FNAC, and we would generally do that. So when you do the FNAC, you get six categories. A non-diagnostic category basically means that you've not had enough cells for the pathologist to report. This can occur in two situations. One, if you have a pure cyst, when you aspirate, you will not find any cells. That does not mean that it's a non-diagnostic. It just means that you're dealing with a cyst which is likely. So if you have a TIRADS 1 and a Bethesda 1, the chance of that being cancer is extremely rare, or in fact, unlikely. If you have some solid areas in the thyroid nodule and that has not been targeted properly when doing an FNAC, then you might miss a thyroid, you might have not get any cells in the FNAC, and that's when you are in a non-diagnostic, because you're supposed to repeat an FNAC trying to target that solid area. And if it comes back as benign, then your chance of cancer is much less. But if it's negative, if it's again non-diagnostic, then you could follow those nodules carefully with ultrasound. Now, the risk of malignancy of a Bethesda 1 is slightly higher than Bethesda 2. You would see that. The reason because is that a lot of the previous FNACs done were blinded and were not ultrasound driven. That's why the risk is very high. In our case, most of our patients who are having cystic nodule or predominantly cystic with a few solid elements generally are usually Bethesda 1 or Bethesda 2, and they don't have cancers. We don't generally send them for surgery. Now, if you have a solid nodule and you get Bethesda 1, then your FNAC is grossly inadequate. You probably have to repeat it properly. Sometimes very dense colloid nodules, you'll get a lot of colloid. You may not have much follicular cells. You might want to use a wide bore needle to get enough cells. Bethesda 2 risk of cancer is extremely low, about 2%. In our series, our risk of cancer is about 2%. Now, keep in mind that if your cancer risk can be slightly skewed up, you see that the percentage goes from 2% to 7%. The Pittsburgh data is up to 10%. The reason why it's a bit high in some series, when you start getting larger nodules. So when you have nodules that are more than 4 centimeters, my negative predictive value or satisfaction with the Bethesda 2 does not rest. So in those cases, maybe you may want to think of other strategies to apply. But in general, if you have Bethesda 2, your chance of cancer is fairly low. Our data suggests that risk is less than 2%. We've not had many Bethesda 2 which have gone on to become cancers. I'll go quickly to Bethesda 5, which is suspicious for malignancy. We hardly get this category because majority of times either they call it Bethesda 6 or they will call it one of the indeterminate categories. So you have non-diagnostic benign Bethesda 2. You have suspicious for malignancy and malignancy. Most of these are usually clubbed together, and the risk of cancer with these Bethesda 5 and 6 is usually more than 95% or close to 100%. Again, I wouldn't say 100%. Most of them is around 95 to 98% chance of cancer, both in Bethesda 5 and 6. And in majority of these patients will require surgery, depending on their risk, lobectomy or total thyroidectomy based on the risk of cancer. We get stuck here between Bethesda 3 and Bethesda 4, and different institutes will have different percentages for the risk of cancer. Bethesda 3, 22%, Bethesda 4, 30%. If you look at the Bethesda 3, it's a wider range. It ranges anywhere between 5% to 30%, some in 45%. The reason for this wide variability in Bethesda 3 is because Bethesda 3 can further be subdivided into architectural atypia and nuclear atypia. When you have an architectural or cellular atypia, then the risk of cancer is much lower. It goes down to below 10%. If it's nuclear atypia, our chance of it having a cancer in our series is close to 60%. So nuclear atypia puts you at a higher risk, whereas architectural atypia puts you at a slightly lower risk. Bethesda 4, 30%. Our data is about close to 40%. 30 to 40% of them are usually cancers. And most of the Bethesda 4 will need lobectomy to confirm your diagnosis. So here's where you're getting stuck whether to offer them surgery or what to do for them. And recommendations from the international guidelines with Bethesda category 3 and Bethesda category 4 is to either, if you can go back and look at the ultrasound, this is a very nice clinical approach that you can follow. If you have Bethesda 3 or 4, go back to the TIRAD scoring. The TIRADs is 1 and 2. You can do surveillance versus ultrasound, or you can do molecular testing. If your TIRADs 3 or 4, then you're really stuck. Bethesda also 3 and 4, TIRADs also 3 and 4. You really need some help. That's why I think molecular testing really helps. And if you have a high suspicious pattern of TIRADs 5, then recommendation is surgery. So it's a very fairly good clinically applicable algorithm that I think is useful in indeterminate cytology thyroid nodules. So here's where I think the extra piece of the puzzle can help us so that we can avoid unnecessary curious thyroidectomies. I call it curious thyroidectomy. You're curious to know what it is. Patient is curious what to do, and you subject them for surgery, and then that creates some complications, and then we end up having problems. Give you some few examples to sort of develop this problem a little better. So this is a 65-year-old female, older women, 3.5 centimeter, TIRADs 4 nodules, solid, iso to hypoechoic with some macrocalcifications, but had Bethesda 3. And Bethesda 3 was oncocytic, a lot of Hürthle cells in it. So we weren't sure what to do. Got a molecular testing in this patient, was BRAF and TERT mutation positive, also had a HRAS combination as well. With this combination of mutations, we were very clear that this patient would need surgery, subjected her for total thyroidectomy, and the final diagnosis was a classic PTC. This is a 35-year-old female, had a fairly large 3 centimeter thyroid nodule, TIRADs 4, because of slightly hypoechoic nature. Bethesda also 4, and we subjected her for a mutation testing, which was negative, and hence was being closely followed up till date and has not changed in size so far, not subjected her for surgery. So this is the flip side of the equation. If you are mutation negative, can you molecular test negative, can you actually wait and not do anything? There's a 34-year-old male who had a large thyroid 4 centimeter Bethesda 4 nodule. We got a molecular testing which showed a PAX8 PPR gamma and was found to have a follicular thyroid cancer with angioinvasion and had thyroidectomy done as well. This is a lady who had thyroids 2, in fact, a benign appearing thyroid nodule. FNAC was done, showed nuclear atypia, got us a little worried, got a nuclear and molecular testing done, found to have an NTRK fusion mutation, NTRK fusion, gene fusion, and that subjected for total thyroidectomy resulted in PTC classic. The 51-year-old male with a 2.9 centimeter nodule with thyroids 4 with interrupted rim calcification, Bethesda 4, a lot of microfollicles, also had an NTRK mutation, infiltrative FVPTC was the final diagnosis. So these are cases to tell you where ultrasound, FNAC, you kind of are in a little fix, how the addition of a molecular testing help. Now, some of you might feel a little out of sorts here because I've been telling you a lot of names and fusions and mutations which you might not be familiar with. But just to get back or rewind back on how this all evolved, this is not something new. This is not something new, and this has been in the guidelines for a while since the 2016 ATA guidelines. But we are trying to get this in clinical practice in India. Very few centers have been doing this in the thyroid nodule practice. So 1950 discovery of driver mutations in thyroid tumors, 1990 PCR in 1993, and then 1990 you came to know of the red PTC. This is where the medullary thyroid cancer was a poster child for mutation-driven clinic genotype-phenotype correlation. Then RAS mutations were noted in 1990, red PTC in those who had thyroid cancer because of radiation was noted in that. Then fusions like PAX8 PPR gamma was noted. Somewhere down the line, BRAF mutations, which were originally found in multiple malignant melanomas, also noted to found in thyroid cancers, particularly the papillary cancer. TERT was found to be a promoter gene in advanced thyroid cancers. NTRK mutations and the other fusions also started becoming relevant in thyroid cancer. So slowly and steadily, we've been able to identify more and more genes, both mutations as well as fusions that are part of the thyroid cancer, and that has helped us understand dividing these mutations into 3 broad groups. Low risk mutations, which are predominantly RAS-like alterations, intermediate risk, which are BRAF-like alterations, and high risk, which are TERT, another high risk multiple mutations as well. So if you look at the broad thyroid cancer-based data, BRAF mutation was found predominantly in papillary cancer, usually classic PTC or tall cell PTC. They're usually infiltrative, common extrathyroid lesions, particularly the lymph nodes, have a higher stage at presentation, usually N1B disease, and they could have a propensity for dedifferentiation and hence less radioactive iodine avidity noted in these patients. The red PTC fusion was seen in younger PTC patients, particularly those associated with radiation exposure, frequent lymph node metastasis. RAS mutation, on the other hand, found to be in about the follicular variant thyroid cancer, particularly the invasive encapsulated follicular variant PTC. Nuclear features of PTC may or may not be present, but more frequently encapsulated, less frequent lymph node metastasis, more frequent distal metastasis. So this is how classic biological behavior and mutations were studied in thyroid cancer. This has enabled us to use these mutations in next generation sequencing. And one of the pioneers in this work is from Pittsburgh, Dr. Nikiforov, who conducted sample of the FNAC samples from thyroid nodules in Bethesda benign, indeterminate, and malignant, and BRAF variants, the RAS mutation, along with the gene fusion products like the RET PTC and PAX8 PPR gamma, were commonly associated with thyroid neoplasia. And he started out the original ThyroSeq panel, which had about a few gene mutations and gene fusions for trying to diagnose thyroid cancer with FNAC itself. And from there has been plenty of material panels in the market, including the ThyroSeq version 1, 2, and 3. You have the Afirma, which is slightly different, which looks at the RNA gene expression classifier and gene sequencing classifier now, and a more recent update on the Afirma as well. So these panels are widely available abroad, and they are useful in helping the clinician give a rough estimate of their risk of cancer. A meta-analysis of the Afirma and the ThyroSeq, which is the commonly used one, tells us that the sensitivity of these panels is very good. However, the specificity is low, even in multiple non-sponsored studies and in other real-world studies. You could see that if you have a mutation, then it is likely to pick up a mutation and is likely to tell you that whether it is cancerous or not. The negative predictive value is very good. That's what the sensitivity means. Very high sensitivity means you have very good negative predictive value. So a negative test has a very strong predictive value, but specificity is low, which means that if your mutations come back positive, you're not sure if they do have cancer or not. So that's where the meta-analysis of these commonly used molecular testing abroad comes from. You also have to keep in mind that there's a lot of things that go into what constitutes this panel, what are the mutations that constitute this panel, and so that can potentially affect the performance of the panel as well. Obviously, one of the pressing reasons for them will be on legality, and hence I think these tests are all driven to have a very high sensitivity, not to miss a cancer. Whereas since you're having a very high sensitivity, you lose specificity and end up picking up a lot of mutations, which may not really give you the idea of having cancer. So it's kind of defeating the purpose in the use in the indeterminate nodules, because then you will be subjecting a lot of patients with mutations for surgery, and they may just be a low risk mutation and may not really have cancer. So that is one of the problems with the molecular testing that is currently available abroad. So what about in India? India, we've not had a lot of studies on FNAC panels, particularly for thyroid cancer mutations. We've had selective panels on galectin-3, P53, and BRAF alone. 6 studies on the cancer specimen for BRAF mutation, and very small numbers as well. So we've looked at the next generation sequencing molecular assay offered by MedGenome in the group of indeterminate thyroid nodules. Now, we've been using this for about close to now 2 years. 69 patients data are available. Now, as you can note, we predominantly picked up the Bethesda 3 and 4. We also picked up Bethesda 2, which are bigger. So when you have a Bethesda 2 that's bigger or has suspicious features of ultrasound, then we also feel that there's a discordance between the ultrasound and the Bethesda, and there's a small false negativity rate on Bethesda 2 in larger nodules. So that also was in some patients were included. We've done FNAC and ultrasound in a single machine and in a single center, and FNAC was collected through the RNA later solution. And of course, Dr. Suruchi can also go over some of these specifics of the NGS panel that constitute what we call the thyroid tract panel. The thyroid tract panel covering 40 unique genes and 37 genes analyzed for the single nucleotide variations and deletions, and 17 genes analyzed for fusions. So a very concise and a very tight panel that is looking at both the mutations and fusions that we've felt that are very important for thyroid cancer risk prediction. And that's what we've been using for the last 2 to 2.5 years now at NH. What we decided is if the molecular test comes back as positive, then we would recommend them to have surgery. And again, based on the positive which mutation, we further fine-tune ourselves whether it's going to be a hemithyroidectomy or a total thyroidectomy. And if it's negative, we will follow them on a sonographic basis. That was our idea of doing this. We had close to around 69 patients so far, mean age of around 41 years, majority of them females, as expected in most thyroid nodule studies. 39% were Bethesda 2, and you see the mean size of the Bethesda 2 slightly close to 4 centimeters, 3.7 centimeters. The Bethesda 3 are divided into the nuclear atypia. As I told you, nuclear atypia have a higher chance of cancer. Architectural and oncocytic atypia also form the next of the list. Of around 43% of our Bethesda 3 were of our samples of Bethesda 3. About 17% were Bethesda 4, and then we performed NGS in about 69. And in that, we had about 45% were negative and 55% were positive for some mutation or the other. Out of the 55% that were positive, 20 patients have been operated, 8 are still under follow awaiting surgery. And among the negative patients, only 3 have undergone surgery and the 28 are being followed up. So that's our plan that we evolved over time. So what did we find? In the Bethesda 2 nodules, this is the nodules which are large and they are come back as Bethesda 2. The predominant driver mutation that is found in these was RAS mutation. So out of the 27 Bethesda 2 nodules, 11 of them had RAS mutation. 3 underwent surgery and all came back as benign nodules. So RAS can be present in benign thyroid nodules as well. When you have Bethesda 2 under RAS, you don't have to get excited about it. And the NRAS is commonly associated with benign thyroid nodule. We don't have data about the other 2 people who had HRAS and KRAS. We did find one fusion in one of the patients with Bethesda 2, and she underwent total thyroidectomy, and that was the follicular variant PTC. So here's the trick. When you have a Bethesda 2, which is bigger in size or growing in size, and if you find a fusion or a mutation that is very highly predictive of cancer, like PAX8 PPR gamma, then you're subjecting them for surgery is important. And this lady underwent surgery and she had a follicular variant PTC. When you come to the Bethesda 3 architectural atypia, this very closely resembles Bethesda 2. Similarly, you have a lot of RAS mutations. So a lot of people had RAS mutations, and even those who underwent RAS mutations came back as either benign follicular nodule disease or this category of NIFT-P, which is a pre-malignant condition, still not gone into cancer, but it's a pre-malignant condition. So architectural atypia also predominates with RAS mutations, generally low risk cancer or pre-malignant condition. One person in the architectural atypia had BRAF mutation positivity, and as expected, turned out to be PTC. The oncocytic atypia is small in number. We had only about 6 patients, but even among the oncocytic atypia, we had 1 patient with BRAF TERT. I showed you in the case studies, and that patient underwent thyroidectomy, and that also came back as PTC. Now, when you look at the nuclear atypia, you have RAS mutations, you have fusions, and you sometimes also have other mutations as well. Interestingly, the patients who had RAS mutations in the nuclear atypia group were likely to get a diagnosis of cancer, either a PTC or a FEPTC. NTRK fusion was likely to be PTC. Interestingly, we didn't find BRAF in our Bethesda 3 nuclear atypia group. But what I feel that is when you have nuclear atypia and you have a RAS mutation positive, the significance of the RAS mutation becomes more important in that particular patient, likely to prognosticate a malignant nodule compared to a similar RAS mutation, particularly in NRAS, in an architectural atypia or a benign thyroid Bethesda category 2 nodule. When you come to Bethesda 4, we had fusions in 2. One is a PAX8 PPR gamma, was an NTRK mutation, and both of them had cancers. The ones with RAS are the NRAS still awaiting surgery, but the HRAS, one of them had PTC with tall cell variant and one was benign. So fusions are seen with the Bethesda 4. We don't have a lot more numbers to actually, tell a little bit details about what is likely to be the outcome of the RAS mutations in Bethesda 4. That's a little difficult at this point to judge and tell at this point of time. So overall, RAS mutation predominates the mutation testing in thyroid nodules. You have to look at the RAS in the setting of your Bethesda score. If your Bethesda score is predominantly a benign Bethesda 2 or an architectural atypia, then your RAS probably has a lower chance of cancer. Whereas if your same RAS comes in the setting of nuclear atypia, you're likely to be dealing with thyroid cancer. The presence of other RAS, HRAS, and KRAS could indicate a slightly higher chance of cancer. You may want to keep that in mind. Fusions like PAX8 PPR gamma or NTRK mutations, high predictors of cancer. All our BRAF came back as PTC, so no questions on that part as well. So our sensitivity is fairly good, 89%. Our specificity is about 79%. Positive predictive value predominantly because driven by the RAS mutation, and negative predictive value, I think time will tell us how much of our mutation negative actually stay put and don't develop cancer over time. So that data is evolving as we speak right now. So I kind of put together a little algorithm towards the end of my talk. So if you have somebody with a Bethesda 2 nodule, which is large and growing, you can offer them the NGS panel of thyroid tract. If you have a negative molecular testing, you could observe them, or you could even give them the option of a radiofrequency ablation. If you have a RAS mutation positive, then you could either subject them to a hemithyroidectomy or a RFA, because chances of you having a RAS mutation with a Bethesda 2 still likely to be benign thyroid nodules. On the other hand, if you have a fusion or multiple other mutations, then I would recommend you subject them for either a surgical procedure, either a hemi or a total thyroidectomy. If you have Bethesda 3, if you have architectural atypia or oncocytic atypia, RAS mutations you can observe or undergo RFA, maybe hemithyroidectomy if required, but most of the time observation and RFA is fairly safe to undergo, or a hemithyroidectomy is safe to undergo here. If you have a BRAF, for sure thyroidectomy. If you have a fusion or multiple other mutations, again, thyroidectomy. If you have Bethesda 3 with nuclear atypia, here RAS mutation portends surgery. You've got to undergo surgery, hemi or total, depending on the clinical case. BRAF, for sure, thyroidectomies, other mutations, possibly thyroidectomy as well. Bethesda 4, if it's BRAF or fusions, thyroidectomies. RAS, again, here, we probably weigh in more towards thyroidectomy because it's a Bethesda 4, and we would want them to undergo surgery in this case. If you have somebody who's mutation negative, you have fairly good chance of waiting and watching. If you have a high-risk thyroid nodule in the setting of mutation negativity, you may consider the possibility of doing a hemithyroidectomy. So we've one of the few centers who've done this for a while now, and I think suffice to say that what looked all very similar on ultrasound, all these nodules look very similar, but they all have different pathological entities, but they all look very similar on ultrasound. And if you do FNAC on all this, you get either Bethesda 3 or Bethesda 4, and you're stuck. But you can now start picking up the ones that have the molecular signature of their final diagnosis. And I think that's what I would like to share today, that next generation sequencing, particularly the thyroid tract panel, is giving us an additional layer of assessment in management of thyroid nodules. It has helped us in comprehensive decision making along with individualized clinical judgment. Again, I make a point that it is not the molecular test only that actually makes your decision. It is the sum total of clinical, sonographic, cytological, and genomics which actually help us make an individualized clinical judgment. Thank you very much. I'm open to questions.
Thank you, Dr. Kannan. I think it was a very well-structured talk where you walked us through the clinical presentation and then discussing the challenges and then the availability of molecular test. walking us through the cases that how molecular tests has helped the diagnostic accuracy in the clinics. And then I think the most interesting part for me was the deep analytics that we have done, looking at the holistic approach where nuclear atypia, Bethesda 2 category nodules with RAS mutations are much more malignant than any other subtype of Bethesda 2. So I think the holistic approach is very important. And then I think the algorithmic analysis was also, I think, very useful for our audience today, where we can actually, based on our data and experience, we can say that how, we have to take the molecular signatures along with the other presentations in the nodules. So I would like to, ask one question. Like you mentioned in the beginning that there can be incidental findings of nodules. So if we have a incidental nodule, which is, by while doing PET, we have identified, and it comes out to be BRAF positive or PAX8 positive. So along with the other secondary cancer, how are we going to treat it basically? So if it is BRAF positive, it has a therapeutic implication as well. So how do we take it along with, say, for example, if it is a colorectal cancer, and along with that we found incidental nodule, which is BRAF positive?
Yeah, I think that's a very, very important question. I think the PET scan positive nodules have to be viewed in the context of the patient's primary cancer. So if the primary cancer is going to be the driver of the patient's lifespan and prognosis, then you should respect that. So suppose somebody's got a advanced metastatic colorectal cancer, advanced lung cancer, advanced breast cancer, you find a thyroid nodule that is 1 centimeter or 2 centimeter in thyroid, and it's BRAF positive, that's okay. I think we don't subject them to unnecessary surgeries and complicate their lives further. But on the other hand, if you have a primary cancer which has got a good prognosis, patient is doing really well, you found an incidental thyroid cancer, either through an FNAC or you've done molecular testing which is suggestive of BRAF. In our settings, BRAF generally implicates PTC. We've not had anybody who've not had a cancer with BRAF mutation. So in those cases, you could decide about surgery. So I think to answer your question, PET positive nodules, I would decide my course of management based on the prognosis of the primary cancer. If the prognosis is good, then yes, you could then work this up as in any other thyroid nodule and offer them the options. But if the primary prognosis is not good, then you're not going to do much favor by trying to do too many testing for these patients.
Okay, and how about using BRAF inhibitor in these cases? This was one case which actually in a recent molecular tumor board we were addressing to. So do we recommend use of BRAF inhibitor in case we are not having any targeted therapy for a primary cancer?
I don't think we have data enough to suggest any new adjuvant kind of therapy right now. There are data in the anaplastic thyroid cancer where both dabrafenib and tenofovir combinations are being used to downstage the disease and then consider surgery both for the high-grade thyroid cancers and the anaplastics. But I think for a nodule point of view, I don't think we have data enough to suggest anything of itself.
Sure. Thank you, sir. We have few questions in chat box as well as in Q&A.
Okay.
So what are your views in BRAF fusion groups? I think that is quite well answered during the talk. Would you like to, Charu, I think it is your question if you would like to add to it.
Yes, so my question is that if a Bethesda 2 category BRAF-like fusion or a Bethesda 4 category BRAF-like fusion is there, like in these two categories, if we get a same fusion which is not very commonly seen, like a BRAF with any other partner, which is not commonly found. So does your clinical management really depend on the Bethesda category as well, in terms of...
You mean to say you're not getting the BRAF V600E, you're getting something else?
Yeah, BRAF fusion, which is a MKRN1 fusion, So in these type of cases, what usually is your clinical management protocol?
We have not had it so far in our nodule analysis as of now. We've not had any non V600
Classical.
mutations as of now. But in my previous paper with our with a similar genetic study, we've had a couple of patients who had the non V600 BRAF mutations, and we have subjected them for surgery, and we've had malignancy in them as well. So my general rule of thumb is if you have got BRAF based mutations, at least if it's not the classic V600E, then I would at least go on for a diagnostic hemithymectomy. But I would also view it along with the Bethesda, along with the ultrasound findings as well.
So if it is Bethesda 4, definitely then there are highly more likely chances that it could turn out to be
So if
malignant.
it's a BRAF fusion group in Bethesda 2, probably hemi. A BRAF fusion in Bethesda 4, probably total.
Okay. That answers my question. Thank you, doctor. Thank you.
Thank you, Dr. Charu. So we have another question from her, like, what is your experience, sir, while using this particular test from MedGenome as compared to the tests that are available abroad?
I don't think I can give you a honest answer because we've not really run a PERMA in our patients, so I can't tell you that. All that I can tell from the way the thyroid nodule molecular marker testing is going along, and you can, I mean, and Dr. Suruchi can add to this as well. You keep adding more and more markers to improve the sensitivity of the test. You really don't want to miss that one cancer. But you lose specificity, and that's what I think. Then you defeat the whole purpose of doing this, because then you are at a stage where, well, you have you get a mutation positive. You're not sure how to interpret that in the setting of the indeterminate nodule, and you have to do a diagnostic. I might as well done the diagnostic lobectomy even before doing the nuclear testing. So I think it's important for us to keep the sensitivity and specificity at a fairly equal rate, and so that you don't lose one over the other, because then it will defeat the purpose.
Right. So I think that's the reason why ATA guidelines emphasized on 7-gene panel earlier, because it's much more focused and we can easily interpret what we want to look for. Plus, I think for this test, the negative predictive value has much more importance, because the clinical advantage will be to avoid unnecessary surgeries, which is like 90% of the total indeterminate nodules, which may turn out to be benign as per the UCLA data. So basically, I think that is the major point. That's why the positive predictive value is mostly lower, I mean, for this particular. But the point that we have to emphasize and look is that negative predictive value is good enough to take the clinical decisions for those nodules which could turn to be benign. So another question we have. Please let us know the procedure to collect sample for genetic testing and what precautions we need to take. I think, Dr. Kannan, this needs a little bit detail, because this is one question which I also hear from a lot of centers when they want to send this test for that, how to collect the particular sample, FNA sample for molecular testing.
So I think we obviously you need to have the RNA later tubes. These are special tubes that you have to put your sample into, and we generally send the sample right away in the morning to the lab, and we don't normally, although there are recommendations to cold store and then send the samples the next day or the day after. But in general, recommendations to send the sample as early as possible in cold chain. The important thing when you're sending a molecular testing is to ensure that you have adequate sample. Initially, when we were starting off with the test, we used to when we did aspirates from thyroid nodules, we use normally a 26 or a 28 gauge needle. It's a very fine needle. We normally would send only whatever is present in the hub as an extra material. After finishing our slides, because we make our own slides. So after we make the slides, whatever little material is there in the hub, we used to just push it into the RNA later tube. Then I realized that our yield was becoming less when we did that. So I would recommend doing a full-fledged separate pass, 1 or 2 passes in the nodule to get material for your NGS panel. So here's how it is. So you got an FNAC first time, you got a Bethesda 3 or 4. So you call the patient back for the NGS. So they have consented to get the NGS testing done. So you call them back. When you call them back, you will do at least 1 or 2 passes in the thyroid nodule. You will put most of the material into the RNA later tube, and you may have some material in your syringe and your needle, which you can actually make smears and send it to your pathologist again. So I always double do the FNAC when I'm doing the NGS as well. And that's very important because as you saw in our presentation, we look at the NGS in the setting of the Bethesda. So we really want the Bethesda to be 100%. We get our most experienced cytopathologist to look at those Bethesda smears so that we get a fair hang of what the Bethesda is and what are we looking at in the molecular testing. So separate pass, 1 or 2 passes. The Bethesda 2 nodules are notorious for giving you very less cellular material. So if you're doing a Bethesda 2, I would recommend using a slightly larger bore needle, either a 23 or 22 gauge or 21 gauge needle sometimes, to get a little wide bore needle so you get more material into your aspirate. The Bethesda 3, 4, and they can be done with a finer bore needle, fine needle as well. But Bethesda 2, sometimes when you're doing because they are large nodules, you may want to get a little wider bore needle to get more material into the RNA in the tube and quickly transport them to the genetic lab.
Sure. Thank you, sir. I think you answered the other question that usually people are having, like whether to do FNA at the time when they are sending it for cytology or to call the patient back. So I think it is best to call the patient back so that we can have a separate pass for sample adequacy. And as you rightly mentioned, in our lab experience also, we have seen that most of the Bethesda 2 category samples, they usually, if the sample inadequacy is there, so it is mainly Bethesda 2 category samples. FNA Bethesda 4, how would ThyroTrack help?
So I think Bethesda 4 is one case where I think ThyroTrack will help in terms of deciding 2 things. If you have a Bethesda 4 and you have absolutely no mutation positive in ThyroTrack, this is a dialysis patient, obviously high risk for cardiovascular disease. Putting him through surgery is going to be a surgical risk. So if you have negative mutations, I would follow him on the ultrasound. If you have a fusion or if you have a high risk mutation, then you are at very high risk of cancer. You could offer them thyroidectomy. If you have, and again, I'm not sure about how to interpret RAS mutation in this setting. You could either decide with hemithyroidectomy or follow up closely. But I think Bethesda 4 is usually viewed with a little bit more suspicion given the number of microfollicles that they're seeing. And so I think NGS will help you in deciding if you have something that's worrisome, like a follicular thyroid cancer or a follicular variant PTC, which is likely to metastasize. And so that is what I really want to find. I'm not worried about if it is going to be a PTC because PTC can be picked up by the FNAC, and usually they don't come as Bethesda 4. Bethesda 4 generally indicates either a follicular adenoma, carcinoma, follicular variant PTC. If I have the presence of a mutation or a fusion that indicates a neoplastic process, then I would subject them for surgery.
Sure. Thank you, sir. Should we go for a molecular testing in Bethesda class 1 and 2 without any atypia?
No. Bethesda 1, no. Bethesda 2, you could consider if there is a large nodule or a growing nodule.
Sure.
Again, these are all not clinical recommendations. These are all about probably more of experience-based statements rather than clinical guidelines.
Sure, sir. Are there any risks or limitations associated with this molecular test?
No, it's the same FNAC that you do, so there is no extra risk to the patient.
Yeah. Sure. I think we are done with the questions. I think it was a very insightful session, and we have had a very great discussion and complete understanding from the beginning till the end. And the message, maybe you can give the closing message, doctor.
The molecular testing is not the one single key that you're looking for to open a lock. It's not. You look at it in a holistic manner. You look at the patient's clinical context, the risk factors, the ultrasound finding, the Bethesda categorization, and finally you put the next piece of the genomics to it so that you have a fairly good idea of what you're dealing with, then deciding what best for the patient with minimum harm or in fact no harm to the patient in this due process.
It's adding a layer, basically. It's adding a layer of diagnosis.